Just to kind of turn it over to our live session, Kathy, with your experience in how closely you work within the CDI arena, what steps preemptively can that CDI specialist take, to prevent denials, or what can their role be, within their day-to-day aspects to kind of potentially make your life a little bit easier, or have a really good understanding as far as where they fit in that denials portion?
So, a few things with CDI. As Chris stated, I do education with our CDI when they come on staff, and I'm trying to gauge where they're at in their practice. Have they come from an aggressive program? Have they come from a more conservative program? Have they trained with on-the-job experience from another CDI? Have they gone through a formal training process? All of those things, because it really gives me a lot of information as far as where they're at. The majority of them have never been through any education regarding denials. And so I set up time with them during the onboarding, and we review some common denials. I think Michelle will be nodding her head, the sepsis, acute respiratory failure, the acute renal failure, encephalopathies. So we go over some of those. I also do audits with them on their queries, because I find that with the queries, there's an opportunity to have additional documentation in that query that supplements the physician's documentation. And so, we look at creating a compliant query, but we also look at that query multiple choice and options that we can include in there that would help supplement the documentation in the medical record. Serve as a resource to them as well as when they're doing their concurrent reviews. Sometimes, they're a little bit nervous. They want to know if something's at risk for a denial, but lots of education with them.
And Kathy, with that education, have you seen that kind of mold with your facility, maybe as far as the trends that you're seeing, and really kind of honing in on almost multiplying your role by providing that education, to the CDI team, and really understanding where that common ground is, and what the reasons are? Obviously, again, you wear a lot of hats. You really focus in, on really what you can achieve, and then bringing those CDIs in. Have you seen again, any specific diagnoses or trends within, your environment that you're able to really target that education, as it relates to those CDIs, and then ultimately let them kind of turn around and educate physicians, because, now you kind of have, again, that common understanding between the denials aspect and the CDI aspect, and kind of being a little bit more proactive rather than reactive?
Sure. So all of my education that I send our CDI is in a PowerPoint format. And I do that so they can take that information if they need to. It's got citations and things on it. They can use that for physician education or education in other departments, because we talk about the fact that we need the dietitians to have documentation for those malnutrition cases. We need documentation from therapy and nursing. These are in addition to physicians. We do talk about specific denials, and so I'll take maybe 3 or 4 of them that we've had that have had some documentation issues, and we will do a deep dive in those, and we will go through the problematic documentation on those accounts. We'll also look at the queries, if the query was helpful, what could have been added to the query to make it helpful. One example would be with acute respiratory failure. We have a lot of denials for those, and I'm sure this is no different than anywhere else, other than you need to understand that my payer mix is primarily Medicare Advantage, so they have their own set of rules basically that they follow. But other than that, we do standard education. So an example would be in a patient with COPD that comes into the hospital. They're requiring some oxygen. Patient isn't on oxygen at home, but they're requiring maybe 2 or 3 liters. Not uncommon for the payers that I have to argue that that is just a COPD exacerbation. They will also argue that we don't have an ABG, but they'll be arguing that what the patient is experiencing is not acute respiratory failure, but rather a COPD exacerbation. And so one of the things that I've discussed with them on those cases, when they're creating their multiple choice, when they're listing acute respiratory failure, one of the other multiple choice options that would be great would be COPD exacerbation without respiratory failure. Because once that physician signs that query, I now have documentation in the record that already disputes what the auditor, what their intended argument would be. So those are specialized things that we can do with our CDI that we can't really teach our physicians that, oh, this is Aetna, they require a blood gas, or, this is United Healthcare, and they also want to see that the patient's on BiPAP. So, we can't go through all those tactics with them, but our CDI can be educated along those lines.
Yeah, and just providing flexibility, right, as far as being able to allow you to pull, if you have that proactive approach, most likely you'll have a couple different options you can use,
yes.
During that denials, right, to allow you the flexibility to kind of pull in what you need to for that specific encounter.
Right.
And anything as it relates to, just the main functions of what you would consider an appeals specialist, just those common characteristics, or, really understanding that track and those items that you need to bring to the table that maybe are a little bit different than just kind of the overall aspect, or what do you think is kind of a good core foundation for the appeals specialist? And then are there enhancements you can turn on as it relates to maybe getting a little bit deeper into, or a little bit further along within your career as an appeals specialist?
Yeah, so the one thing I would say, regardless of whom you have as your appeals specialist and their background, you really need to have somebody that is self-motivated, because we don't have a whole lot of information out there as far as training appeals specialists. I mean, we'll listen to some webinars here and there, but we don't have a whole lot. And so we have to really be self-motivated. We have to work on creating libraries with information that we can cite, have comfort in understanding peer-reviewed literature and citing it. I would say that, it's also important as you're writing appeals, you have to establish relationships with your payers and your auditors so that you have a contact person that you can network with to get information, to share information so that it can help you to get your appeals in more timely. It gives you opportunities sometimes to get extensions if you have somebody that that you can work with. I think there's some other things though. We keep up to date on issues with denials. So, we have to be up to date on regulatory issues. We have to know to let people know if we're seeing trends, right? So if I have a trend where I have severe malnutrition denials, that's something that needs to be looked at if it's coming on with any frequency, because that's a target for the OIG. So, we have to wear multiple hats. We're creating templates.
Yeah.
We're analyzing trends often to see where we are with our denials. Do we have any type of trend that we need to be aware of? Also looking at our appeals that we've overturned. What did we say in this argument that resulted in a favorable decision? Also working with our folks, like for me, it would be with managed care for contracting, because I need to give them, has to be a feedback loop so that they're aware of the difficulties that I have from an appeals perspective that they need to be aware of when they're doing those contract negotiations.
Absolutely. And those so definitely the takeaways during that process, right, and the different levels of appeals, and using that as a debrief, almost as like a case study, but still good, bad, or indifferent, right, kind of those takeaways. But I know we were talking about this earlier, really being able to focus on that one particular encounter though, right? And being able to pull in what you can, what you can't, and then you can almost kind of utilize that aspect too from a payer source, right? And really sticking to the script as far as what the documentation and coding is telling you, as well as those medical necessities, clinical validation, and really being able to kind of isolate it down to that one particular case, right?
Right, and I'm sure Michelle will go in depth on that as far as with the templates, because I know she and we've talked, so I'm sure she will.
Cool.
Yeah, she's great. But yeah, it has to be, as you're arguing the appeal, it has to be specific to this patient, this encounter. Yeah.
Right, for sure. And then Michelle, just switching gears, to your side. Are there any industry trends, that you're noticing in denials that would really kind of resonate with the audience? I mean, I know that we've kind of touched on some of the big ones, right? Acute respiratory failure from our survey we had. Excuse me if I don't say this correctly. Metabolic encephalopathy. I believe I did say that right. And AKI and things of that nature. But anything that you've seen from that payer aspect to really maybe ratchet up denials in any of those environments, or anything that you've seen in your day-to-day?
Thanks so much, Chris. And thank you for the kind words, Kathy, and for the great introduction, Chris. And it's great to be with you all this afternoon. So the number one thing that I really want to call to everyone's attention, and this has been really a game changer in the appeals and denials work, and this has to do with Medicare Advantage plans that your hospital doesn't have a contract with. And the appeal process has drastically changed with Medicare Advantage plans that are non-contracted. And it's not that the rules have changed. The rules are long-standing, but the Medicare Advantage plans were not following the rules, and they were misinterpreting the rules, and they were basically applying their own interpretation of the rules. So last September, CMS basically told them that in the instance where they are dealing with a provider that is non-contracted, that the provider has to have all of the same appeal rights as if the patient had traditional Medicare. And what that means is the provider only has to submit one written appeal to either the payer or the payer's third-party subcontractor. And those are the third-party reviewers like Cotiviti, OmniClaim, Equiclaim, and so forth. After that one written appeal, if the finding is in any way adverse to the provider, the payer or their subcontractor is supposed to forward all of the information. So that would be the denial, the medical record that's been submitted, the appeal that the provider's already submitted, to an independent review entity that is contracted with CMS. And the independent review entity then completes their review. And if that review is still in any way unfavorable to the provider, then the provider can request an administrative law judge hearing. And the time frames to request the administrative law judge hearing and to submit the appeal to the independent review entity and so forth are the same time frames that exist for a traditional RAC appeal. And why this is such a game changer is before being reminded that the Medicare Advantage plans, that they had to follow these rules, they were basically saying you could do 3 levels of appeal with them, and then you could do a peer-to-peer, and then you could even take it from the third-party reviewer to the payer, and they'll review it directly. The problem with all of that is there was never anybody looking at your appeal that didn't have a financial stake in the outcome. Now you're having an independent party look at your appeal that has absolutely no financial stake in the outcome. And better yet, you're going to an administrative law judge hearing. And definitely the administrative law judge also has no financial stake in the outcome of your appeal. And also in connection with this, they are supposed to let you know that you have these appeal rights in your denial letter. they were reminded that they can't refer you to their provider manual or the remittance advice or the EOB anymore for your appeal rights. If they're going to deny payment in whole or in part, either because they're removing a diagnosis code and changing the DRG, or there was a coding error in sequencing of the principal diagnosis, or any of those types of reasons, they have to fully tell you in the denial letter the reason for the denial and what your appeal rights are, including where the appeal needs to be submitted, how much time you have to submit the appeal, and so forth. The other important thing that I need to let you know about to take advantage of this process is that with your appeal, you have to submit a waiver of liability. And basically what the waiver of liability is it's just saying if you don't win and aren't able to collect this money from the payer, you can't bill the patient. Because it's a DRG-based denial or a coding-based denial, the hospital can't bill the patient anyway. So you're really not losing anything by sending the waiver of liability, but it's basically sending the waiver of liability with your appeal that triggers these appeal rights that really, in my experience, since I've been asking, and I did mention, by the way, that they're supposed to automatically forward your appeal. They're certainly not doing that. I've actually had to submit letters after the unfavorable level 1 appeal and ask them to forward the appeal to the independent review entity. And I will tell you that I have received a great deal of pushback from many of the payers saying they don't have a process to do this. They're sending one up. They'll set one up. It'll be in place by the end of first quarter of 2021. But in the meantime, they're not going to do anything with the denial that's already taken place, and they're recouping the money. It's fine that they don't have a process. It's fine that they're not setting anything up until down the road, but they can't take your money back until this process is in place and until the independent review entity has had an adverse finding to you. So I guess, Chris, for us, this was just a huge game changer.
Yeah, definitely. So I would say the biggest takeaway from that is definitely know your rights, right? Or understand kind of how you can even the playing field as far as, what responsibilities fall on both sides, right? The facility and the payer side, right? And really having an understanding of that and then being able to kind of build out from there.
Absolutely. And if people want to read more about it, the information was in RAC Monitor dated September 24th of 2020. And then there was a very good discussion about this on Talk 10 Tuesdays, which is a podcast. The podcast was September 30th of 2020. And the specific person that was talking about it was Dr. Edward Hugh. And he was approximately 19 minutes into the podcast. He is actually one of the people that met in person with CMS regarding this, that prior really to COVID hitting. And they basically went to meet with CMS in person to clarify that these appeal processes did actually apply to non-contracted Medicare Advantage plans, even if it was just a partial denial. And that's how they thought they were getting around it, is they were saying as long as they weren't denying the claim in full, that they didn't have to afford the providers these appeal rights. And they now know differently. And I have slowly but surely gotten my appeals either, for the most part, honestly, everything's been overturned. I've only had one that they have actually forwarded to the independent review entity.
Wow. So definitely, again, I think that going back to, Kathy's earlier point, from an appeals and denials management perspective, educating CDIs, allowing for us to understand what the process is, both when it comes to those rights, again, as the facility, but also, those other proactive measures that we can kind of put in along the way to allow when it does get to that point and you do understand what playing field you can be on, you can have that flexibility, and being able to really rely, on the substance, of the documentation within that one particular realm, and then utilize, like you said, that playbook, if you will, or those other areas that come into play that you can always have to your benefit, because we know the payers are looking for something for their benefit all the time, for sure. And then, Kathy, as it relates to, anything that you can touch on as far as what you would consider, the most difficult denial, that you've seen in appeal process you've either personally gone through as far as kind of where you're at, or just in general, any of those ones that are a little bit trickier than others, if you will?
Yeah, one that I'm dealing with recently is the postoperative acute pulmonary insufficiency. That one is very difficult. I mean, you can search and search and search. Most often in my appeals, I cite up to date, but I will also look for additional peer-reviewed literature to cite in the appeals. But those are very difficult because you can't really, I've not found any specific definition for that diagnosis. And so what we run into are situations where they're expecting the patient to meet criteria for acute respiratory failure. But if it's acute respiratory failure, it just becomes difficult because I think sometimes, I know years ago, like back probably around, I want to say 2012, I know we were using that more often because we were trying to help our quality folks with PSI 11. But that one's kind of difficult. I think also the encephalopathies are somewhat difficult because there's you don't have specific measurements that they're looking for, much like you're talking about AKI or respiratory failure or sepsis. So anytime that they can find any type of gray area in insufficient documentation, that becomes a problem. But a lot of it, and I would say this is probably across the board everywhere, has to do with that darn copy and paste. And we've got normal physical examinations throughout that medical record. And, so auditors pick up on that. There's, conflicting information in the record. You're telling me the patient is comatose, but, 7 doctors saw the patient and said they were alert and oriented. So, those are, I think, the difficulties that create the most problem. It's never the ones. So,
no, I was going to say, so one of the things we could do proactively is either take away the control button, the C button, or the V button on a keyboard, right? So you can't copy and paste all day, right? We'll force them to use their mouse, which will take them a little bit longer of a time.
Never show them how to add a normal physical exam. Not ever.
And Michelle, how about for you? Kind of same question, right? Anything that you've seen in your experience that tends to be a little bit more difficult from a denials perspective, again, whether that be isolated to a diagnosis or just anything personally as it relates to your experience that was a tough one to kind of go through, and any particular reasons as to why?
So the most difficult appeals that I have had to write are the appeals where you don't have a denial letter. And this is with, for example, a contracted payer. Basically, you get an indicator on the EOB that they don't like your diagnosis code or that they don't like your principal diagnosis. They don't tell you why, and they don't tell you when they don't like your principal diagnosis, they don't tell you what principal diagnosis that they do like. So when you're in that situation, and I have had to write appeals with that little bit of information, what you basically have to do is be a detective, read the medical record thoroughly, and figure out why they don't like it, and either be able to make an argument to support it. If it's the principal diagnosis, then you have to figure out if you agree with them that principal diagnosis is not supported, what principal diagnosis should be supported, and make that argument. I've also had to do some administrative denials that our facility has gotten from time to time. And when the administrative denials come, they basically just have some very generic language associated with them and generic reasons. And so you basically, for those, you need to go through the medical record and your claim with a fine-tooth comb and address and change anything that could have been done incorrectly, and that could need to be fixed. And you need to write your appeal and try to cover anything in your appeal that you think could be a problem to the reviewer. Those are really tough because you're really shooting in the blind and you're not exactly even sure what you're addressing. But so far, by using the method that I described of just going through everything with a fine-tooth comb, so far I've been very successful in winning those.
How about any of those areas that you have to go through with a fine-tooth comb that maybe have produced more value than others? Maybe, any different areas maybe that provided some information for you, or is it just pretty much all across the board?
It's across the board, but I will tell you one of the trickier things that I have had to deal with is what is the day of a procedure that you put on the claim when the procedure starts before midnight and ends after midnight.
Oh, interesting.
And that can be a reason for a denial. And so what should be the procedure date when you're in that situation and you have to put a procedure date on your claim?
Got it. Well, hey, that's a really good piece of information for sure. Just those little subtleties, and then shifting gears back to Kathy.
Well,
Kathy, what do you? Oh, I'm sorry. Go ahead, Michelle.
Well, let me add one more thing, Chris. I've had it get even trickier than that. I have looked at a medical record where anesthesia started prior to midnight, but the surgeon didn't make the first cut till after midnight. Then what is your procedure date? What's the definition of a procedure?
And where would that come into line? Is that something that would more fall on the facility, kind of really putting in a standardization to that, or do you feel it's better to have that flexibility? I mean, I know it causes confusion, but what are your thoughts on that from those time discrepancies or just time challenges, if you will, if you cross over into the next day?
I would recommend to look for CMS guidance on the issue, and I think you can always be safe with their guidance. In the situation where anesthesia started before midnight, but the procedure didn't start until after midnight, I don't think you'd be wrong using either day because arguably procedure actually does start with anesthesia. They are kicking off the procedure even though the first cut wasn't until after midnight. So I think you're fine going either way, but I would say the safest thing that you can do in that situation is look to see what guidance CMS has and follow that.
Cool. Well, definitely good advice. Kathy, anything along those lines? Have you seen that where that kind of procedure crosses that threshold and seen any of those impacts from where you're located?
I haven't. No. I would say, and I don't know if Michelle has this with her facilities, but one of the things that's always been recommended is to have the CDI insulate that DRG with every MCC and CC to prevent that denial. And I can tell you where I'm at, that doesn't work. Every single one of those MCCs and CCs are validated. So it's not uncommon for me to have 4 or 5 diagnoses in an appeal that I have to argue. That's actually pretty common. But I've had a lot more than that even.
Interesting. No, and that's definitely a good point, right? As far as again bringing back that clinical validation piece, and I know both kind of everybody's kind of touched on this a little bit. When it comes to those contracting negotiations and things like that, is that and Kathy, I guess starting with you, is that something where you've seen either through your experience or just in general, kind of those key stakeholders maybe outside the traditional route? Any heads of state from CDI or coding or any of those kind of different areas discussed during that contracting portion at all, or kind of how does that look at least within your facility as far as securing those contracts and ultimately things that are needed to be abided by within those?
Okay, so as Michelle was talking about the Medicare Advantage, almost all of mine are contracted. And so we have, with different ones, we have different levels of appeal, but as she was stating, they're not always forthcoming, even when they're contracted, about your appeal rights. And
Right.
so I've had to work with managed care because, I had an issue where initially one of the payers was only giving us 30 days for a first level of appeal, when in the contract it was supposed to be 60. So I made sure to follow up on that. I've got a few things now where, like the plan is the United Healthcare, so I'm supposed to have 12 months to appeal it. And the plan administrator is only giving me 30 days. So
Wow.
I've been working with managed care to get the language that I need to send in the appeal, and then also sending it to my counterpart with the auditor, so that I can let them know I know what our rights are, and now I know that you know what our rights are.
Right. And I think that goes back to Michelle's earlier point, right? Understanding kind of those other procedural processes that have in place. So it seems like, at least based off of this discussion, right?
Yeah.
Time is on our side, or maybe against us when you're talking about procedure before or after midnight. But also, it seems like from a contracting perspective, you could take 12 months and then turn it into 30 days. It seems, huh? As far as kind of, what their requests are. But no, I think those are very, very good points. And then same question to you, Michelle. Anything as it relates to your location or your experience as far as how involved is coding and CDI or those departments within any of the contracting perspectives. And I know it seems like, based off our conversation, yes, obviously you can use the contracting to your advantage, but still sometimes there's still some wiggle room from a payer perspective, or at least they try to, right? So just kind of stepping back, Michelle, have you seen where CDI departments are a little bit more involved in those contracting aspects or anything along those lines?
I don't think historically that they have been, but going forward in the future, I think that it is excellent for CDI to be involved in the contracting process, including especially on the diagnoses that Kathy mentioned that we're all challenged on, to put the clinical definition of that diagnosis into the contract so that the payer has to adhere to that. So if your facility uses, for example, Aspen criteria for severe malnutrition, to say that in the contract. If your facility has clinical criteria that they use for acute respiratory failure, to put those clinical criteria in the contract. If you use sepsis too, you put that in the contract, and so forth. If you can put those definitions in the contract, then it really narrows the window of what when they're reviewing, they can deny in relation to that diagnosis. They can't just impose whatever criteria they want to make up or change as they go along. So
right.
I think that's a very important thing.
And I feel like that was part of the conversation, at least when we were talking, me, you, and Sherlivia, at least initially, she was taking on that portion. And again, we'll get her recording up, but kind of allowing that flexibility. I believe it was that Aspen and GLIM, right, kind of meeting, from a criteria standpoint, and then, understanding how you can kind of utilize one versus the other, or potentially parts of one, to reinforce another, or things along those lines. And that kind of goes along what you're saying as far as whatever your specific health system or facility has in place for those, I don't want to say those gray areas, but those areas where they have to pick up the baton and make a call, right, as far as kind of what policies are they following, and being able to put that in the contract, or at least have discussions about that, in your opinion, or at least allows you to now have a little bit more solid ground to stand on, you think, when it comes to those sort of passing of the baton moments where the facility has to make a call as far as, what their philosophies are as it relates to certain diagnoses?
Yes, absolutely. And another thing, too, that you could put in a contract that would be a great catch-all is to simply say that as long as the clinician in the medical record is using a reasonable clinical basis to support the diagnosis, you can just say in your contract that a third party reviewer or the payer cannot come along and apply a more stringent set of criteria for the simple reason to just remove the diagnosis. And then as long as your clinicians are being reasonable in supporting their diagnoses in the medical record, that really, you should be able to just stand on that and on what the clinician at the bedside has decided after they examine the patient, treat the patient, observe the patient's response to treatment. That's really where the diagnosis should be taking place, not in somebody looking at a piece of paper down the road.
Right, for sure. No, that absolutely comes into play. And shifting back to Kathy, in your opinion, as it relates to, I know Michelle kind of touched on it, but do you have any formalized, or any tidbits of information to kind of build upon Michelle's, I think, initial, point as it relates to just requesting information, right? Understanding what the process is supposed to be. Do you feel like that is kind of par for the course when it comes to the confusion maybe that kind of comes along with the, initial shock and awe from a denial coming in, and really understanding not only what the process is as it relates to maybe that particular payer, but also, I think for you, definitely touching a little closer to home as far as what the internal process is for the facility, right? I knew, again, Olivia had kind of touched on this in our past conversations, but kind of having that one entry point to kind of come in, really honing on facility processes so you don't have, a bunch of hands in the pot at the wrong time, educating the CDIs, really, making them, proactive appeals and denial specialists, but then really when those denials do come in, not only administering the facility process as far as, okay, what do we need to do, but then also that process as far as what kicks in based off of what you feel or what are adhering to the guidelines from, that particular denial from the payer. You think those processes kind of align with each other? Like you kind of have to have both internally and then obviously, from a plan of attack as it relates to a certain payer denial?
Sure. I think with the payers, I've had accounts like Michelle's talking about, and probably one of my biggest offenders is Aetna, where they just say that the claim the diagnosis isn't supported on the claim. And then, of course, we do have the times that the denial letter doesn't come in, or it's an APR DRG, and you've got to figure that whole piece out. But understanding where what you can expect from the payer is very important as you're writing your appeal, and then the argument. And sometimes what argument I use for one, I definitely won't use for another, because I found that maybe with this payer, if I just do it in this specific format, that I'm more likely to get it overturned rather than arguing in a different way. Yeah, but definitely, it's both, knowing both.
Right. So knowing the payer, and then obviously, the internal process with those key stakeholders. So, everybody kind of knows what their course of action is right at that time.
Yeah. And you also have to make sure that you trace that point of entry for that denial letter from wherever it comes and how it gets to you, so that you get it timely. Like I said, some of them I only have 30 days. If it's one from the QIO, the initial letter comes and I only have 20 days. So those have to be moved along pretty quickly with the workflow. And then
absolutely.
The feedback, and I think there's also probably a lot of differences. Also, I think Michelle signs her letters and sends her appeals out. All of my appeals are reviewed by a physician advisor for the program, and then the hospital physician advisor. So it's a quick turnaround time to get an approval, but that's our process for Valley.
And you feel like that definitely aids in your ability, having those other internal mechanisms, at least in your environment where you are, that definitely helps in reinforcing, I would imagine, kind of the overall vantage point, from the facility's perspective.
It helps in the sense that every appeal that I send out, I explain why it was denied. So, I'll say this is a denial, this is the criteria they use. let me tell you about the documentation in the medical record. And so that helps our physician advisors when they do education with the physicians, or they're trying to decide with, different entities what type of education is needed, or how we're going to do our training with our residents, based on some of the documentation issues that we find. And a lot of times with the metrics they have for CDI, it's not surprising that those physicians that score low for them are also an issue that I have on my side with the denials. But part of the reason that I do the denials education myself is because it's more of an in-depth review with the CDI versus, it gives them an opportunity to look at the account. Maybe there's something I missed. I'm not perfect. Maybe I didn't see something that they saw. But it's always helpful to explain things to them. It's non-punitive. I don't know what they were going through on the day that they were reviewing it. I have no idea how many cases or whatever. But we talk about a variety of issues with the documentation, and what we could do.
Yeah, absolutely. And again, I think just utilizing the tools and resources that are available at the facility, right? Well, not every facility is going to have the same, right? And utilizing those to your advantage.
Like, my appeals may be more of a clinical type of appeal because I was trained to write appeals by a physician. So I may have more of a clinical type appeal. Somebody else may write one that's more of a statutory argument and has a lot of different arguments in there. I think it just depends on your training as far as your denials specialist.
Yeah, no, for sure. And you must be reading the notes that I've written down, because that was going to be, my question for Michelle as far as kind of taking that legal hat and perspective. Anything that you apply to outline or just added features from that legal background, whether that be a format or just anything that tidbits of information that you kind of pull into that experience, along with obviously your clinical side, that maybe you've seen as far as being successful, within your path?
Absolutely. Thanks for asking that, Chris. So, just a quick overview of how I organize my appeal. I start out my appeal with basically saying whatever our position is in the first paragraph. In the second paragraph, I kind of do a summation of why we're correct in our position, and then say that I'll explain it further after pertinent parts of the medical record. Then I include pertinent parts of the medical record, and I include anything that supports any piece of evidence that I can find in the medical record that supports my position. And then I verbatim put in whatever the reason for denial is from the denial letter. And I always try to look at their authoritative sources that they cite, because many times what is actually in the authoritative source that they cite actually really supports my position. And then I also look at my authoritative sources, and then I state the authoritative sources, and then I apply those authoritative sources to the facts in my case. And then I conclude again stating what exactly it is that we're saying our position is. And the most important legal part of that I learned to do in law school is not just stating what the rules are, but stating a thorough application of how those rules apply in your specific fact situation.
Nice. So definitely use, I guess their position can potentially be used against them if utilized in the right way, right? And you have all kind of the supporting documentation. So don't just take it from one vantage point, right? List both, right? Like you were saying, and then really figure out maybe how one's defense, if you will, from a payer source may turn around to become some sort of an advantage or an offense for the facility at some point, if you're able to kind of link those up together, and either align those correctly or reinforce your position, or essentially potentially show maybe why the discreditation is there because of what's isolated to that one event that they're taking a look at.
Absolutely. For example, I was working on an appeal yesterday and I was reading the authoritative source that the reviewer cited, and there was a paragraph in there that basically said that all of this information is not meant to take away from the clinical judgment of the clinician. And in almost any clinical criteria reference, there is a paragraph like that that you can use, and you can use that to emphasize again the importance of the clinician at the bedside that examined the patient in determining what was going on with the patient and what they're treating.
No, absolutely. And then just a good question came in as far as, Kathy, do you find that certain payers may be a little bit aligned a little bit differently as far as citing, credible sources or, inputting that information and materials in there? You feel that maybe certain trends within payers you can identify on subtleties such as that, as far as always citing those credible sources, or maybe being a little bit vague or ambiguous as far as their approach specifically to, again, just benchmarking payers against themselves?
Well, some of them that I have, they don't even cite the source, and they don't if it's been reviewed by a clinician. But I can tell you that if they are a clinician, you would never want them to care for you because they don't do a clinical review. So, so some of them don't cite sources. The others that do are pretty consistent. Sometimes they are right. And, I think sometimes our CDI have that pocket guide, and they rely heavily on that pocket guide, but that pocket guide doesn't have definitions for every single diagnosis that we have a denial for. So that's why the education is important. But yeah, some of them, they have their ways. I would say that a lot of times what happens, even when they use a definition that's a standard definition, you can go in and review that record, and they just haven't reviewed it. Obviously, and those are.
Do you think that should be one of the questions? Do you think that should be one of the questions, like first initially stated? Have you reviewed this medical chart actually, or no? You know what I mean?
I haven't said that. I have said perhaps the reviewer reviewed a different account.
No way. Are you serious? That's hilarious. That's awesome.
But you look at it, and especially like with sepsis, they're saying that the patient didn't have an altered mental status. There was no acute kidney injury. The SOFA score is 0. They want to try to use that SOFA score, and they want to pull out any type of chronic disease that would elevate the points on there. And so it's usually pretty terrible. Those, the SOFA's much easier to find than you would think, but yeah.
No, that's great. And Michelle, kind of same question, right? As far as I'm sure some are a little bit better than others as it relates to payers and being able to really kind of monitor or provide the information they need to. But have you seen kind of those trends as well, where not citing credible sources or just kind of not providing the clarity or causing a little bit more confusion, as it relates to those denials when they come in?
Yes, and also when you're dealing with a contracted payer and you have to submit more than one level of appeal, like Kathy said, perhaps they didn't read the medical record. There are times when I feel like, and I put in my next level of appeal, perhaps you didn't read my level 1 appeal. So
interesting.
And it's the same thing, because they come back and say exactly what they said in the original denial letter, even though you have thoroughly explained to them in your level 1 appeal why they're not correct. They just repeat themselves.
Right. Yeah. So for sure. So definitely stating that, almost stating the obvious is a good line of defense, I guess, would come out of that, right? Like, as far as having reviewed the correct medical record or having reviewed level 1 or things of that nature, and kind of getting that out there, during that process. could be definitely utilized, either in those additional levels that do come into play, or at least as a benchmark and frame of reference. Kathy, just kind of wrapping up, any final words of wisdom, or any tidbits as it relates to just the denials management appeals specialist kind of overall review?
One of the things that I think is important to point out, because a lot of times you'll have third parties that offer to come in and write appeals, and they have great promises for you. But, we don't have a whole lot of metrics for us in appeals, because there are a lot of things that are beyond our control. And so, we may even know every step of the way to take it, but, if the system doesn't want to take it that far, then, we're limited by that. But really looking at the quality of the work that's completed, and understanding that we don't really have metrics as far as an overturn rate, because there are so many variables that are beyond our control. But looking at the quality of that work, and the validity of the arguments that are used. So that's basically what we use in our metrics for our program. And I've reached out to some other folks. I think Michelle and I have even talked about this before. But the metrics that we have, even looking at the timing of writing an appeal letter, because you can imagine if I write an appeal for one diagnosis, that's much different than when I have to write those for 4 and 5 diagnoses.
Right.
There's a lot of variability there when you're trying to come up with your metrics, your KPIs that you want to monitor.
Yeah, and that kind of ties into a little bit of Danielle's earlier presentation, right? Being able to really understand the process within the denials management realm within your facility to start to have those foundations kind of come into play as far as productivity, or processes, or just steps to go through communication, just those other areas. I think really reinforcing the importance and the commitment level within the denials management program with the facility, at least in my opinion, is one of the major questions, that needs to be asked. How committed are you? Do you really want to have a process in place? Do you really want to, kind of dissect everything to where you have an understanding, and those key stakeholders know what to do, when, and how to do it? Or is it just kind of confusion because you're getting, paper denials, electric denials, they're coming into case management, quality, CDI, coding, probably one coming to my house, who knows, right? Like they'll send them anywhere, as far as kind of causing that confusion, and really, just honing in on that process and that collection to funnel through kind of one chain of command, or one swim lane for communication, I think is definitely an area to, close out some of that outside chatter to really focus on the task at hand.
I agree.
Yeah, for sure. And then, Michelle, same thing for you. I mean, any other, final overall vantage points, or anything from our discussion that kind of comes into play, from our perspective, or our conversation on denials management?
What I would say about this type of work is, the most important thing in this type of work is persistence, and to not easily give up. And
that's a really good point.
And to stay focused. And you're always going to have the payer tell you no because of this and no because of that. And if you're right and you can create another avenue to do that, this type of work isn't just about writing and submitting the appeal. It's about beyond that, figuring out what you have to do next to protect and get the appropriate reimbursement for the care that you gave, so you're able to give care in the future.